Good morning, everyone. This is a tall rounds. That's the third of the amyloidosis series. So last fall, we did a tall rounds on the diagnosis of cardiac amyloidosis and did a deep dive into that. This past spring, the second series was on the treatment of cardiac amyloidosis. And so today, this third series is after you've made the diagnosis of cardiac amyloidosis, how do you follow these patients longitudinally? So I do want to thank this educational grant for partial support of this activity, Alexion Pharmaceuticals, Alnylam, and AstraZeneca Pharmaceuticals for making this possible. We're going to start with a case presentation. Our fellow, Dr. Alvin George, who's a fellow in heart transplant, will present this case.
So this is a pretty typical patient that we actually see in our clinic. So this is a 77-year-old African-American male. He was seen as a consult for heart failure in 2018. He has a past medical history of well-controlled hypertension, heart failure with the diagnosis of hypertrophic cardiomyopathy at this time, paroxysmal AFib, and as well as bilateral carpal tunnel syndrome, spinal stenosis. Review of systems is negative for peripheral neuropathy. His vitals are within normal parameters on these medications listed here below. This is just a snapshot of the parasternal long axis on his echocardiogram, and we can appreciate some asymmetric septal hypertrophy here with a dimension of 2.0 centimeters, as well as a posterior wall thickness of 1.3 centimeters, something typically we would associate with hypertrophic cardiomyopathy. His initial echocardiogram showed sinus rhythm, PAC, some low voltage in the limb leads, and prominent voltages in the late lateral leads without formally meeting criteria for LVH. This is his apical four-chamber view, so you can appreciate the LV hypertrophy here as well as biatrial dilation. His mitral inflow demonstrated a grade 2 pseudonormal filling pattern, and we can also appreciate a prominent L wave here as well. Based off of these studies, an amyloidosis evaluation was initiated, and that was started with a light chain survey. And his kappa lambda ratio was just a bit over the normal limit, but normal nonetheless. And he did not have a M protein spike on immunofixation. His biomarkers were notable for an NT-proBNP of 3100, a troponin of 0.035, and creatinine of 1.4 with a mildly reduced GFR. PYP scan demonstrated grade 3 uptake, and SPECT imaging also showed diffuse myocardial uptake as well. He underwent genetic testing, and that revealed a V122I variant, and he was diagnosed with hereditary ATTR amyloidosis, or also known as transthyretin cardiomyopathy. And so at this point, we're often faced with three questions in particular. So what is the prognosis of this pathology? What are the treatment options that are available, and how do we go about monitoring this patient?
And I'm just going to give a brief 10-minute big picture. Just to reframe where we are, remember the two most common types of amyloidosis that affect the heart are AL or light chain amyloidosis, which is a plasma cell clonal disorder, or the much more common type, transthyretin or ATTR amyloidosis, in which the liver-derived protein transthyretin is what's leading to the amyloid fibrils. So this is the focus of today's tall rounds. And remember, when the fibrils deposit, they deposit throughout all the myocardium, atria, ventricles, conduction system valves, stiffening the heart, and ultimately causing a variety of clinical presentations, most commonly heart failure, but arrhythmias, sometimes looking like hypertrophic cardiomyopathy, like you just saw in the case presentation. So when we diagnose somebody, that first visit in the office is actually very anxiety provoking for the patient. When they see the word amyloidosis, what do? They immediately go to the internet, and a lot of outdated information about survival is in the internet. There's an old paper that says that when you get diagnosed with cardiac amyloidosis with heart failure, you have 6 months to live. And that was in the context of AL amyloidosis, and that's very far from the truth, even in that particular condition. So the current prognostic staging systems, there were three that were developed, one from the Mayo, one from the National Amyloidosis Center in London in the middle, and then the Columbia staging system added a little nuances. So in the Mayo staging system, they look at troponin T and NT-proBNP. And if your NT-pro is less than 3,000 and your troponin T is less than 0.05, you're considered stage 1. If one or the other is above that threshold, you're stage 2. And if both are above that threshold, you're stage 3. The UK staging system is a little more practical in that it just relies on NT-pro and estimated GFR. And the cutoffs are, again, NT-pro 1,000 and a GFR less than 45. So if your NT-proBNP is above 3,000 and your GFR is less than 45, that would constitute stage 3. Now, what the Columbia group did is they looked at a cohort and showed that New York Heart Association class and diuretic dose added to the staging system as far as predicting outcomes. And basically, you get points for what UK stage you're in, and then you add the NYHA class, and then the degree of diuretics you're on. We all know that the higher the diuretics, the sicker the patient. So there you can see the staging system. In general, if you're stage 1, your survival is about 5 to 6 years, stage 2 about 3 to 4, and stage 3 about 2 years. But what's extremely important is these staging systems were developed in the pre-treatment era. So when you're sitting in front of a patient and you're saying, well, this is what your predicted prognosis is, I tell them that this really doesn't hold water anymore because this was more natural history. Now that we have treatment, this is completely incorrect. And remember that as far as the treatment, we've been able to, by understanding the biological underpinnings, knock down production of TTR by the liver, stabilize the tetramer, and now a couple antibody studies that we're involved in to try to actively remove the heart. Now, full disclosure, still the only FDA-approved drug for this condition is tafamidis in the middle there. It stabilizes. It's an oral drug that stabilizes the tetramer and is meant to slow down the progression, best case scenario, stabilize the patient. So when you're sitting there and telling them about the diagnosis, you say, this is a medication that's been FDA approved since May of 2019, and you have to have the conversation that this likely will slow down your condition, best case scenario, stabilize it, but it's not going to reverse what's already there. And so the patients always say, well, how do you know it's working? And I tell them the only way to know it's working is to clone you, give your clone a placebo, and give you for the next 5 years tafamidis. And even if you progress, you probably are going to progress a lot more slowly than if you weren't taking the medicine. Recall that this trial for tafamidis was published in 2018, showing a very significant mortality benefit with a number needed to treat of 7 to 8 patients over 2.5 years. The patients who enrolled this trial were sicker, average NT-pro 3,000. Many of you now are diagnosing these patients with NT-pros in the 1,000 range because of better recognition. Remember also that in the trial, they looked at 6-minute walk and KCCQ quality of life score. Even in the tafamidis arm, still at the end of 2.5 years, the 6-minute walk decreased by 50 meters. So the KCCQ also decreased on average. Now, obviously on placebo, it decreased a lot more, so you're slowing down progression. But again, you have to prepare patients for this potential. And if you look at the echo parameters over time in a post hoc analysis of that study, even the tafamidis arm still decreased EF mildly, decreased stroke volume, and a little bit worsening strain. Obviously better than placebo, but we don't expect the echo to get better. So how do you assess disease progression once you put patients on this medication? 3 ways. You look at the patient, you look at biomarkers, and then you can look at imaging, and you take that constellation and tell the patient you're stable or maybe you have mild progression. So the patient in the office, you're asking them what they can do. You kind of come up with an NYHA class. We don't do routine 6-minute walk tests every 6 to 12 months. I just talk to the patient. Some people advocate this. For me, it doesn't necessarily change management, so I don't do it. But diuretic dose is something I pay attention to. Now that we have SGLT2 inhibitors, oftentimes these patients may not even need a loop diuretic. But the more loop diuretic they need, the worse off they are. Have they been hospitalized? Obviously, that's a marker of progression. Have they gone into AFib? I'm not sure that's a marker of progression because the nidus is there to develop AFib, so it doesn't necessarily mean you've progressed, but we look for those kind of things. This is a paper from the NAC about the prognostic value of 6-minute walk. In short, basically, the lower your 6-minute walk is at baseline, under 350 meters, the worse your prognosis is. And if you worsen over 35 meters in 1 year or by more than 5%, that's increased hazard ratio for mortality. Makes sense. The other thing that we look at is outpatient diuretic intensification. You'll see this term called ODI. It's all over the place now, even in HepPath trials, because we all know that when you have to gradually increase the diuretic, that patient is getting worse. So this particular paper looked at outpatient diuretic intensification at various levels versus none. And the worst survival were those where you had to increase the Lasix more than 40 milligrams. Again, a marker of worsening survival. And when you combine that with NT-proBNP progression, and this paper was greater than 700 or more than 30%, you can see that the hazard ratio is significant. So the combination of NT-proBNP progression, outpatient diuretic intensification, portends a worse survival. So we talked about the patient. We talked now about biomarkers. Again, the NT-proBNP really fluctuates. So patients freak out when it goes from 1,500 to 2,100. And that could be because they had 2 slices of pepperoni pizza the day before. So you follow that every 6 months and you kind of look at a trend, and oftentimes it'll bounce around. And I try to tell them not to, look at it to the letter of the law. Now, prealbumin, you can order prealbumin levels, and guess what? Prealbumin is transthyretin. It just never changed the name. And so a normal level is 20 to 40. When you give a stabilizer, the level goes up by 6 or 7. So sometimes, as a poor man's way of looking, is it stabilizing? I'll look at a prealbumin level. And just to finish off, the third part, and you can see I didn't focus on this much, is looking at the imaging. And often these echoes don't really change that much. You can look at the ejection fraction, the wall thickness, the diastolic function, the LVOT VTI, look at the valves. In general, I don't get this more than once a year. The patients really want it, but oftentimes it doesn't give me tremendous information. Repeating a PYP scan over time right now is not validated. We don't do that. We have seen regression in the uptake, but we don't really know what that means. So we don't do that. Cardiac MRI, Dr. Kwan's going to talk about that in more detail. It's a really interesting tool to be more quantitative about what's happening. And there's some very interesting PET agents that also can be quantitative. Just a quick mention, this is unpublished data. We looked at wall thickness measurements, and just to note that inter and intra-observer wall thickness variability is significant. So I don't tend to pay attention to the reports. I look at it, but again, it's not strikingly important. So just to end here, that 77-year-old African-American male with a hereditary ATTR cardiomyopathy that Alvin just presented, who presented in April 2018 with an NT-pro 3000. He was about NAC stage 2, predicted survival of 3 years because of his V122I. Yet we were able to kind of get him on these other medicines we used to use. When tafamidis became available in the extended access program, we got him on that in October 2018. Then it was FDA approved. He went commercial. Then we enrolled him in the Helios B trial, which randomized him to vutrisiran, which is a silencer versus placebo. Then he got into the open label extension. He's been getting drug for over 1.5 years. And here he is over 6 years later, NYHA2, NT-pro 1550, EF in the 50s, stage 2 diastolic function. So this gentleman's lived 6 years, and quite frankly, I think his trajectory could be another 6 years. So obviously and this is what happened to his NT-proBNP over time. But at the end of the day, although we're diagnosing people early, middle, and late, the fact that we have treatment now, we can monitor progression and now potentially regression. So with that, I'll introduce Dr. Kwan, who will talk about cardiac MRI as a tool to monitor these patients.
Thank you for the opportunity to talk about cardiac MRI and how this can be used to assess progression and treatment response. So as we all know, CMR provides very comprehensive phenotyping. It gives you this vast array of really synergistic imaging features, going from gold standard LV size, mass, and function, We can also provide strain, myocardial perfusion, flow, atrial mechanics, and then most importantly, tissue characterization with T1 mapping, ECV mapping, and late gadolinium enhancement. And all of these imaging features get very interestingly impacted by amyloid deposition. So I also just wanted to provide this diagnostic imaging algorithm. That there's two different guidelines with ESC, AHA. I'm not going to go into this into detail. And we often focus down here in the diagnosis, and CMR has somewhat of a limited role, but in this paper recently published, CMR is actually up here as a modality when you're looking at patients who have clinical red flags, shortness of breath, LVH. You're not quite sure yet what the diagnosis is. CMR is an important modality to rule out other causes of LGH, such as hypertrophic cardiomyopathy, Fabry's, etc. So CMR does have a role upstream, potentially, in patients with shortness of breath. So in terms of prognostic imaging features, amyloid is just such a fascinating disease entity in terms of imaging because there's so many different imaging features from nuclear, echo to CMR that manifest and help us diagnose this disease. In terms of prognostic assessment, CMR really provides a lot of important features in terms of thickening of the myocardium, systolic function, stroke volume, strain, LGE, T1 mapping, and ECV. So really this gives you a very comprehensive assessment of what's going on with the myocardial substrate. In terms of findings in amyloidosis, I just wanted to highlight that in a cine image, you can have very similar degree of LV thickness, but actually the degree of amyloid deposition within that thickened myocardium can be very different. So in patient A, you can see there's a thickened myocardium, which looks very similar to patient B. However, the T1 mapping is quite different. Patient B has significantly higher T1, native T1 time. You can look at the LGE. You can see there's definitely more LGE deposition or enhancement in patient B. ECV mapping is 62%. Normal is 28 to 29%. This patient above also has elevated, but you can see patient B is significantly more. And you can also see on the perfusion map that the perfusion in patient B is definitely almost half the patient A. But if we go back to the morphologic features just in terms of LV thickness, what you could see by echo potentially would be very similar. In terms of TTR amyloidosis, definitely PYP scan is the imaging modality that helps us diagnose the patient. But this was a really interesting study from the UK demonstrating that if you just look at grade 0 and grade 1, there's actually a lot of different phenotypic imaging features that you can see with CMR, and focusing just on grade 1, these are the different degrees of LGE enhancement that can be seen in a grade 1 PYP scan. So going from no LG all the way to very diffuse LGE. So this really provides you further phenotypic assessment in a patient with grade 1 PYP scan. In terms of imaging characteristics, this is a study that demonstrated regression versus progression. And as Maz had highlighted, with echo, it's very hard to see small changes with treatment. Probably the best imaging feature on echo is strain. So the strain can potentially show that it's improving with regression versus not changing or getting worse. But again, it's very difficult to tell from patient to patient. This is in contrast to CMR. So you can see with CMR, with the LV thickness, you can see a little bit of regression, but it's very striking actually when you look at T1 mapping, LGE, and ECV. This is a patient that had diffuse LGE with treatment. You can see very striking regression. And this patient, unfortunately, did not respond to treatment. And you can see that there was not that much LGE to begin with and striking progression over time. And again, in this patient with progression, there was not that much increase in LV thickness that you could see with echo. This was some other studies demonstrating CMR's ability to look at treatment response. So regression with cardiac amyloidosis has been seen with AL amyloidosis with chemotherapy, as well as with patisiran for ATTR. And in 42% of the patients, there was a decrease in LV mass. And again, because CMR is a gold standard and allows very precise measurements for LV mass, you can actually quantify this and see this with a smaller number of patients. So decrease in LV mass, decrease in LV volume, and decrease in ECV, and a significant with significance. ECV increase also correlated with decrease in biventricular function and increased wall thickness. So again, these are very striking differences in terms of late gadolinium enhancement from baseline to follow-up, and this is a very striking response to treatment. Okay, what about change in ECV? This is probably our best quantitative measure by CMR. LGE is very easy because just when you see it, it's present or absent. But actually getting quantitative assessment with LGE can be a little bit tricky because of changing gadolinium kinetics and creatinine in these patients. So quantitative ECV is probably the most quantitative imaging feature that we can look at. So this is a study in patients with AL amyloidosis and TTR amyloidosis, and they looked at ECV volume, stabilization or decrease versus increase in ECV volume. And this quantitative assessment during treatment demonstrated that if you stabilize the ECV or improve the ECV, these patients have significantly improved prognosis compared to those who have progression of ECV. So this is really a nice tool that we can tell patients how you're responding to treatment. And this study was very interesting to me because ECV requires requires contrast administration. In this study, they looked at native T1, which does not require contrast. So this potentially could be done without contrast in a shortened study. And they demonstrated that patients who have decrease in T1, so that's getting better, had significantly improved survival compared to those who had increase in T1. And so you see those patients with increased T1 at 6 months. So this is at a very short time interval. You can see a very striking separation of curves in terms of prognosis. And again, this can be done without contrast. So this is a really exciting study to see that with non-contrast CMR, you can get a lot of information, both the LV mass, function, and native T1. Okay, this was a recent study that was presented at ACC looking at acoramidis, and again demonstrating that you can see improvement in LV mass, stroke volume EF, strain, ECV, and also RV function with this second generation agent. It's also a stabilizer. But I thought this was really interesting. So as Maz pointed out, this is a slow progression. So in patients with sustained amyloidosis progression, this is over 30 months, you can see the increase in ECV is on the order of 2 to 3% each year. And in terms of stability, it was really stable at 12 months. Then only at 24 months do you start to see regression at 64, then 58. So really it takes a while and many patients to actually see a response and decrease in ECV. And lastly, I just wanted to point out this really interesting study that looked at CMR to look at multi-organ cardiac amyloidosis response. So the nice thing about CMR is you don't only look at the heart, you also see the liver and spleen in the field of view. And you can do T1 mapping and ECV in these organs as well. And basically, they demonstrated that if you have a decrease in or regression of amyloidosis, you can see a stark drop-off in the amyloid deposition, particularly if you see a drop-off in the liver and spleen, because these are the organs that produce and cannibalize the amyloid fibrils, if you will. And so this on the other side, on the contrary side, if you have increase in amyloid with progression, you can also see this in the liver and spleen as well. So it's a multi-organ problem, obviously, but with CMR you can evaluate all of the organs in the field of view, which I think is very interesting. So just quickly to say that I think that it's really exciting to see AI coming into the field. I think this will greatly enhance our ability to diagnose, but also predict outcomes and potentially predict which patients may respond better to which agents. We have the multi-imaging data that we can collect here. There's really interesting things that we can do with radiomics and different convolutional neural networks. And this can allow us to really get to precision medicine for our patients. So in conclusion, CMR plays an important role in characterizing the extent of the disease, which provides important prognostic implications. CMR enables precise quantitative measurements to assess interval regression versus progression of cardiac and multi-organ amyloidosis deposition. With multiple therapeutics on the horizon, CMR may emerge as an important imaging modality to enable patient-specific treatment selection and treatment response. Thanks so much.
a lot of patients with atrial fibrillation has amyloidosis, and a lot of patients with amyloidosis have atrial fibrillation. So we have to screen patients. This disease, actually, they can coexist. So you guys have to have an open eye to making sure that this patient doesn't have these two diagnoses. I'm just going to cover a few things, especially for the EP community, because we see these two diagnoses occurring at the same time. We see patients with atrial fibrillation. We read a lot of EKGs. If there's a significant discrepancy between the QRS morphology, between QRS amplitude and the left ventricular hypertrophy, start think about amyloidosis. I usually use these criteria. So in summary, if you have a small QRSs and you have a thick left ventricle, start thinking about amyloidosis, especially ATTR amyloidosis. Is atrial fibrillation common in patients with cardiac amyloidosis? Unfortunately, yes. A lot of patients with amyloidosis have atrial fibrillation, and we have to be careful about diagnosing them early, because the prognosis is impacted if you diagnose these patients early. What we see is patients with wild-type amyloidosis have higher prevalence of atrial fibrillation. That's simply because they are sicker and older and they have more comorbidities than other individuals. But what we clearly see is that the more advanced the stage of the disease, the higher the risk of atrial fibrillation. What are the risks of patients to develop atrial fibrillation? The number one risk is technetium pyrophosphate uptake in the atrium. This is some data from our institution here. What you see is that the degree of technetium uptake in the atrium will predict atrial fibrillation in the future, irrespective of how much it's being deposited in the left ventricle or the right ventricle. So even patients who have isolated atrial amyloidosis, what you see is that if you just see it purely in the atrium, their prognosis of developing atrial fibrillation is much, much higher in the future. So we have to be careful about these individuals. So teaching point one, these two diseases coexist. You have to be careful about making sure that if you're an atrial fibrillation specialist and you see features that suggest cardiac amyloidosis, do the workup. If you're a heart failure specialist and you suspect that they have some symptoms to suggest paroxysmal symptoms, then worry about atrial fibrillation and do screening. So what about the management of atrial fibrillation? A lot of times we say, okay, am I going to rate treat them? Am I going to rhythm treat them? Am I going to give them oral anticoagulation? Which oral anticoagulation I'm going to do? So let's go over some of these data that we have. Rate control strategy in these individuals are very tricky, because patients, when they go into atrial fibrillation, they lose their atrial kick, so the cardiac output will drop. And the only way they can compensate is by increasing their heart rate. So we have to be very careful about over-rate controlling these individuals, because these individuals, their only modality of increasing the cardiac output is by increasing the heart rate. So, and the other thing that we have to be careful about these rate control medications, especially when you're dealing with digoxin and calcium channel blocker, you have affinity for these fibrils to attach these medications. So you have to be very careful about calcium channel toxicity, blocker toxicity, as well as digoxin toxicity. What about antiarrhythmic medications? Class 1C agents, we know it's a bad strategy because a lot of these patients, they have scarring in the atrium and the ventricle, predisposed them to atrial flutter and ventricular tachycardia, as well as they have a small vessel ischemia. When it comes to class 3 agents, sotalol and ticusine is a concern because a lot of these patients have renal dysfunction, so we're left with amiodarone. But we have to be careful about amiodarone because it's also a sodium channel blocker, so it will promote conduction disease, and we have to be careful about these individuals. So what about atrial fibrillation and risk of stroke? A lot of times when we're dealing with the risk of stroke in patients with atrial fibrillation, we follow the CHA2DS2-VASc score. In this patient's group, please, we should not be looking at the CHA2DS2-VASc score. The CHA2DS2-VASc score is near useless in this patient's group. If they have cardiac amyloidosis, irrespective of the CHA2DS2-VASc score, they need to be on oral anticoagulation. In fact, if you look at patients who have cardiac amyloidosis without atrial fibrillation, the risk of a left atrial appendigeal clot or left atrial clot is not very low, and they can develop that. So when do I give them oral anticoagulation? Usually if they have atrial fibrillation, or if they've had prior history of a left atrial clot or left ventricular clot, they need to be on oral anticoagulation. We don't have clear data that everybody needs to be on oral anticoagulation in the absence of AFib or a clot. Which medicine do I give? Do I give warfarin? Do I give DOAC? This is also some of our group data here, suggesting that when you look at the Medicare database, if you give DOAC, then actually, in fact, they have probably slightly better mortality. So at least this is encouraging that we can try these DOAC agents in these patients group, and we don't have to rely on warfarin. This is a very important question that we get asked a lot. When we do a cardioversion and the patient had cardiac amyloidosis and they were on blood thinner, should I do a transesophageal echo? This is some of the work that was done by our previous fellow here, Owen. So if you look at patients who are with TTR amyloidosis coming to the lab for TE cardioversion, you'll find that 30% of these patients have left atrial appendigeal clot. And if you look at these individuals, you'll find that it's not uncommon for them to be on oral anticoagulation for more than 3 weeks. So these individuals could have a clot despite being on oral anticoagulation for 3 weeks. And actually, some of them had atrial fibrillation for less than 48 hours. So this is a different group of patients. So I think you have to be a little bit careful about doing a DC cardioversion individual, even if they've been on a blood thinner, especially if they had a prior TEE showing significant left atrial appendigeal myopathy, meaning left atrial velocity is less than 20%. So in summary, rhythm control is probably better than rate control, because rate control medication, you can restore the sinus rhythm. TE is probably reasonable to do it before every cardioversion, and DOAC may be a very reasonable option to warfarin. A lot of these individuals who have atrial fibrillation also end up with atrial flutter. That's simple because they have a lot of atrial scarring. That could be in the form of typical as well as atypical flutter. Again, for the EP community here, so this is another patient that we see is that we're seeing a figure of 8 flutter that's happening in the left atrium, or they could have even a more complex flutter where the flutter could involve the right atrium, the left atrium, and the coronary sinus at the same time in patients with amyloidosis. And that's simply because of the degree of atrial scarring in these individuals. So a lot of times we end up doing AFib ablation in these individuals. So is this a good thing to do AFib ablation in these individuals? This is some of our data here looking at TTR amyloidosis. What we see is that, yes, AFib ablation works better if you do it in early stages. And these patients actually do better if they are actually do AFib ablation on them than just rely on antiarrhythmic medications. But we see patients who had AFib ablation, their survival rate is probably slightly higher. And what we see is that patients in sinus rhythm, their survival rate is better after atrial fibrillation versus patients who've done AFib ablation and you failed to restore sinus rhythm. So what about oral anticoagulation if they do very well after an AFib ablation and restoring sinus rhythm? For example, these patients who come in because of repeated nosebleeds and they're falling, but at the same time they're in sinus rhythm. Can I stop oral anticoagulation? We think that's a bad idea because this is a patient that I've done who has atrial amyloidosis. And what you see here, red is scar tissue, is tissue inside the heart that's not generating a significant depolarization. And what we look at, especially if you look at the left atrial appendage, is pretty much all dead and all scarred. So even if they are on sinus rhythm, these patients should be on oral anticoagulation the rest of their life. And we know that this is also data showing that the CHA2DS2-VASc score is pretty much useless in predicting left atrial clots as well as stroke in these individuals. So for these patients who we are concerned about oral anticoagulation, we do offer them left atrial appendigeal occlusion. We have a small data here that from this institution showing that it is very reasonable. And so far, patients on follow-up, they do very well without significant risk of stroke. So what about conduction disease? It's not uncommon in patients with amyloidosis. The most common feature you see is that sinus bradycardia and then first-degree AV block. First-degree AV block is not that benign in patients with cardiac amyloidosis because what you could have is balanced decreased conduction in both the left and the right bundle. So when I see patients with first-degree AV block, you want to exercise them. You want to make sure that once you increase the heart rate, they can continue to conduct because that first-degree AV block that you think that it is benign, when you in fact exercise them, what you see, the sinus road picks up and then they end up with complete heart block. So you have to be concerned about these benign conduction disease that you see in other individuals, especially if they have symptoms. And what other features about conduction disease is that progresses with time. So a first-degree AV block one day, after a year or two, they end up with complete heart block, like for example, in this individual. And what we've seen here from this institution, we see is that hereditary TTR has higher risk of AV block, and that AV block actually can progress with time compared to the wild type TTR. What kind of pacemaker do I need to put in these individuals? Again, this is also small data from our institution saying that if you put a CRT in these individuals who you expect that you're going to see high burden of RV pacing, they do better than putting a DDE pacemaker. They're less likely that the mitral valve mitral regurgitation is going to get worse, less likely that the left ventricular ejection fraction is going to drop, and they do last longer and the mortality rate is lower. We don't like to put a His bundle pacing because we know that the disease usually is infraHisian disease. So we can either do a bi-V pacing or a left bundle pacing. So what about ICD? We don't have clear guidance about whether patients should be getting ICD in this group, and the reason for that is because a lot of their ventricular arrhythmia is non-sustained. Usually they have poor prognosis, but we'll see if the drugs that we have now that's going to change the prognosis of these individuals. A lot of times they get ventricular arrhythmia when they're very sick, that the shock is unsuccessful, and often when it is successful, they end up with PEA and they arrest. So we usually like to rely on ICDs for secondary prevention unless we're dealing with patients with AL amyloidosis and they have non-sustained arrhythmia. This is some of the data with TTR from Cleveland Clinic showing that we didn't see a significant improvement in mortality, whether they get patients with ICD or no ICD. However, patients with AL cardiac amyloidosis, usually could be a little bit younger individual. Their disease is very aggressive. It's like a myocarditis thing. So if they have non-sustained ventricular tachycardia, if they have good prognosis, it may not be an unreasonable, but you have to discuss that patient one patient at a time. So in summary, AFib is not uncommon in cardiac amyloidosis. Try to get them in rhythm, treat them with oral anticoagulation, screen for conduction disease. First degree AV block is not that benign. It can progress. Use CRT therapy if you need to pace them. And we have definitely some work to do when it comes to the role of left bundle pacing as well as left atrial occlusion in this individual, and more importantly, whether the medical therapy for amyloidosis will change the arrhythmia outcome in these patients. Thank you very much.
When all fails and we have a patient with end-stage heart failure, then we seek to see if a patient is a candidate or would benefit from heart transplantation. And so we'll talk a little bit about previous studies in amyloid patients, about our experience here at Cleveland Clinic, and what are the future directions we see in this field. So to start, we have this patient, 63-year-old African-American male, has a heart failure with preserved ejection fraction. You can see that he has significant LVH on his echocardiogram. His EKG, just like Dr. Kanj was explaining, the typical findings that we see, low voltage in the limb leads, we see pseudoinfarct pattern. So this patient, there was significant concern for amyloidosis, and so he actually underwent a fat pad biopsy, which was negative. Here we haven't had a lot of luck with fat pad biopsy. The yield has been low, so we actually don't do it as much, but he also had some CKD, and so went for a renal biopsy, and actually that was also negative. So ultimately, the decision was to recommend endomyocardial biopsy, which was consistent with TTR amyloid. When we have a patient with TTR amyloid, we got to make sure if it's a patient with a variant or not a variant, and it's wild type. And so in this case, he did have a variant, the V122I, and so that was definitely positive, and it was a hereditary ATTR or ATTR variant. So early reports in heart transplant with amyloidosis were mainly in AL, mid-1980s to early 2000s. A majority of these patients actually did not have chemotherapy or stem cell transplant after heart transplant, and so they actually died of recurrent amyloidosis or systemic amyloidosis. So the survival rates were really low, as even 30% at 5 years. We can see that from this study from 1991, we see that the amyloid population that underwent transplant, their survival was much worse, around like 50% at the 5-year mark. And compared with the ISHLT registry with other cardiomyopathies, it was significantly different and much worse. We have from this paper, again, they focus on that before it was a contraindication to do transplant in amyloidosis, heart transplant, because of the potential amyloid deposition that could occur in the cardiac allograft. And the concern was that there could be afterwards systemic progression as well of the disease that could, make the prognosis of that patient much worse and the outcome worse as well. Another study in London done a decade after, kind of confirmed that patients that have amyloidosis that undergo transplant versus non-amyloidosis have worse prognosis. And when you compare even with the medical therapy, it's even worse than that, the patients that underwent transplant. So it kind of leaves you with bitter taste when you see this data. Is it something that benefits patients who would be doing it? And so it's important to note that one more thing is when you do these heart transplants, well, if they're TTR, they're a variant, and you're at risk for systemic amyloidosis, do you do a concomitant liver transplant? And so now with the new therapies that like the silencer specifically, we can control those polyneuropathies that are pretty debilitating, and so these patients now have much better outcomes, and we'll see following in the following slides. Coming back to that patient, he ended up having end-stage heart failure. He got a transplant in July 2008. We decided not to do a liver transplant, so it was only a heart transplant. It's always important with these patients to look for all the other extracardiac manifestations. Like this patient had macroglossia with like tongue involvement. Here, with permission of the patient, Dr. Hanna and Dr. Jacob, who took care of him after his heart transplant. Dr. Estep looked at this when he was at Methodist. He had 22 patients with amyloidosis, with 17 had AL and 5 ATTR, 17 with 2 being heart and kidney, 1 heart and lung, and the 5 ATTR is 4 being heart and liver. And this is kind of the sequence that he did, or the protocol he took with the patients with AL. They got their chemo, usually Cybor D, then they underwent transplantation if they had responded. Then they would continue the chemo if necessary, and as soon as they could restart it to control the disease. And then they underwent stem cell transplant at the 12-month mark. So they saw that 12 out of the 17 patients, were alive at the time of the publication. 5 of the 17 died, and these are the reasons on the right and the bottom why they died. So it was important to distinguish which patients would benefit potentially from heart transplant. And so the things that they looked at were like the hematologic, was that they didn't have CRAB criteria consistent with myeloma because those patients do worse. If they have potentially less than 20% plasma cell clone, if they have renal involvement, if the GFR was less than 30, so they would try to pick somebody who had a GFR at least 30 to 50. If they have proteinuria, that try to pick somebody who had less than 500 or at least in the 500 to 2000 range. GI involvement, no mucosal involvement or malabsorption, liver involvement or severe neuropathy or autonomic dysfunction. So we see that for very selected patients with clinically isolated cardiac disease, 5-year survival in that population was significantly lower than heart transplant recipients in 5-year survival. But the newer data suggests that the 5-year survival is more than 50%, approaching to 70%. So things have changed, at least in these patients with amyloid. And some patients even live more than 10 years. And the importance of catching the disease early is, if we think that these patients need heart transplantation and they need to go on the list, if they don't get transplanted, they have a very bad survival and a high mortality in these patients compared to all other diagnoses, as you see in that graph. And when you compare the MGH data on the amyloidosis, which is on yellow, versus dilated cardiomyopathy in red and other restrictive cardiomyopathies in green, you see that in the end, it's kind of similar, the survival post-transplantation. Mayo experience also looked at AL when they kind of confirmed same findings that the Dr. Estep had seen. And if you look there in the era 1, like before, from 2002 to 2010 to 2007, you see that the survival at the 5-year mark was not as good, but in era 2, it has improved significantly. You see it on the blue mark there, where the survival is much better. And the other question with the AL patients is when to do the stem cell transplants. And so in this population, they had patients with TTR and AL, and the ones with AL, 2 had a heart and kidney, and 1 had a heart alone. A lot of these patients have CKD, and so you always have to have the consideration if they need a concomitant kidney at the time of heart transplant. And so some of the things that we look out and we have to be aware like I mentioned before, is if they have significant GI involvement. Sometimes they need GI biopsies to just make sure how severe the disease is. If they have liver involvement, sometimes we also need a biopsy of the liver if they have significant portal hypertension or cirrhosis. If they have renal disease with a GFR of less than 30 or more than 2 grams of protein in the urine, if they have significant neurological disease with severe lifestyle limiting orthostatic hypotension or peripheral neuropathy, if they have a symptomatic myeloma, like I mentioned before, or if they have recurrent effusions indicating that there is some pleural involvement or lung involvement, that also is something that we look out and we take into consideration when we talk about these patients in our transplant committee meetings. Just an overview here of these patients on their survival. The majority alive, and a lot of them actually had a good survival, like I had mentioned. And now, that as we see in the other paper, the survival with every year and every paper that we see has been improving. So to look at the Cleveland Clinic experience with cardiac amyloid, we've done now about 58. This was data from about 6 months ago. 22 were light chain amyloidoses, 32 were TTR, and 1 ApoA. And then from the TTR, 8 were wild type and 24 were hereditary. So talk about the ATTR first, 32. So we see that the majority were hereditary. The main variant that we saw was Val 122 isoleucine, and 8 of them were wild type, which is the second highest population or biggest population. The baseline demographics, we saw that the ATTR hereditary, the majority were African American. No surprise with that variant, which is more common in that population. And in the ATTR was more common in white patients. We see that the age of diagnosis was about 63 in the hereditary and 67 in the wild type. The age at transplant was 65 and 1, and then 69 for the wild type, and month to transplant was about 13 in both. We see that a lot of the patients with hereditary ATTR, no surprise, had more neuropathy. Some variants do have that combined phenotype of cardiac and neuropathy. And also, both populations, one patient had autonomic neuropathy. We see that post-transplant, these patients with ATTR, a lot of times we wait some time, usually at least more than 6 months. It varies with provider because we don't really have enough data to say, well, after we transplant them, do we start tafamidis, or when do we start tafamidis? And so hopefully in the future we'll have some answers with that question. But in the patients that did have neuropathy, we did do silencers at a certain amount of period, and we always rely on the help of our neurologist to do that. The mean follow-up that we have for these patients is about 3 years. The ones with hereditary ATTR did end up being admitted a bit more. Deaths were similar in both, and there were more rejection in the wild type ATTR. This is the survival that we have, at least for ATTR. All ATTR for 1 year is actually 97%. At 3 years, 84%. At 5 years, it's 79%. So better than the studies that we have been seeing before, which is great. In our patients, actually, the wild type was the one that had kind of drove the survival a little bit lower. It was 69%. And these are the patients with wild type, the red patients that have disease. As you see, the one on the top, the patient has been alive for more than 15 years. And then this is just in a curve, the survival. Median is about 5 years. So the hereditary ATTR, similar, just in a graphic, we see that it takes up to the 15 years, the green with each patient there. Now talking about light chain amyloidosis, we have that it was about 22 patients. Males were 12, female 10, and white 20, and black patients 2. Median age of diagnosis was a little lower, it's 58, and same with the median age of transplant. It was also lower than the ATTR at 59. Time to transplant was about 4.9 months, so it was less. It was other organs that were involved that we saw was kidney about 32% of the time, lungs about 13%, liver 1%, and GI 9%. We did heart, kidney in 6 patients, and we've done stem cell transplant in 4 of them. And then we saw projection more than 2R in 5 of those patients. No recurrence in ATTR or ALs, so same thing for the ALs. We did have some, about 41% that they were admitted more than one time. And median time to first hospitalization was about 8 months, just one death. One death was at the 1 year mark on a patient that was actually really sick, but all the other patients are still alive. We see that something that's really important is their hematological response. And so as you see, the majority of patients actually responded to the newer therapies that we have, which now we use CyBorD with daratumumab. And at the 1 year mark, now compared to the paper that Dr. Estep published, we're doing less stem cell transplant. We follow them really closely in our amyloid clinic with the help of Dr. Valent. And then because we're following them closely, we can decide if we need stem cell transplant or not. But with the new therapies, they've been responding so well that we haven't had to do that in the majority of the patients. And then lastly, the APOA1, we had one female patient that was transplanted in 2022. That's the only one, the APOA1 that we have besides the AL and the ATTR. So future directions, because we have better therapies now with CyBorD and daratumumab, we don't necessarily now have to do stem cell transplant. That's what we've been seeing in our practice. And so that's something that we've been just kind of kicking the bucket, and we always have it in case we need it, but we find ourselves not needing it the majority of times. It's really important in our Tuesday meetings, at least, and when we are presenting at our Advanced Heart Failure and Transplant Committee, to look at these patients to see what systemic involvement they have. And not only that, but also look at their AL specific information to see if they pretend more risk or less risk and something that's viable. And then in terms of ATTR amyloidosis, now we have much better therapies. And so that really has precluded the need for doing liver transplant. So that has been our practice, not doing a liver transplant. We just do single heart transplant because with the silencers, with the stabilizers, and in the future, hopefully with the depleters, if at any point we need them, I don't think so. Probably with stabilizers and the silencers, that it'll help these patients a lot. And then the other thing is that we've been following up these patients as well. And we have seen that the cardiac allograft usually is not involved. There have been cases where some variants have been more aggressive, and when they've done biopsies routinely, we saw it at the International Society of Amyloidosis that they have recurred, but it's not something that happens commonly. It's more rare. Thank you.
That wraps up the various talks, and we have some time for an open discussion. So does anybody have any questions? Miriam?
I feel like we should be putting people up for advanced therapies a little sooner if we follow them with MRIs and see like ECV is changing. I mean, do we have that data yet to say, like, is it good enough to say if you do this percentage of progression in your ECV, you're going to have a terrible outcome in 2 years or something like that? Because maybe their BNP is 3,000, 4,000, 3,000. I mean, do you know what I'm saying? Like, we watch them, they all have limitations. Sometimes it's hard to tell who you should be talking to first.
Yeah, I think here at the clinic, we haven't been doing CMR routinely for follow-up, so we don't have that data here. But I think the data that I presented is pretty compelling. They demonstrated those separation of curves at 6 months. If your ECV got increased, or even if your native T1 increased, there was a very striking difference in survival. So I think that it could be a great tool at 6 months to know, like, which trajectory is this patient going.
Yeah, thanks, everybody. This is for Dr. Khan specifically about the prediction of AFib and amyloid. Do you ever empirically prophylactically anticoagulate people if they have a really high atrial uptake, but you haven't seen any AFib, but you're pretty sure they're going to get AFib sooner or later?
So that's an excellent question. Should we anticoagulate all patients with amyloidosis, irrespective if they have AFib? Unfortunately, we don't have data. If you look at patients who have sinus rhythm, the risk of stroke is higher than patients who have atrial fibrillation, and some of us think it's because they're not on blood thinner. However, small clinical trials that were observational clinical trials to look whether if you give them anticoagulation, it did not affect mortality, and that was mostly offset by the significantly higher risk of bleeding. So right now, the clinical indication for oral anticoagulation is AFib, clinical atrial flutter, or prior history of LV or LA clot.
Thank you.
I'll just make one comment. So, Mo, I have many patients who have a first-degree AV block and obviously I follow their EKGs every 6 months or do it more frequently if there's an issue, but I don't see is a major issue, and you said it's not benign. So I obviously they can progress to further conduction disease, but almost all of them have some degree of first-degree AV block.
Yeah, I'm sorry. I didn't mean it to say that it's a bad thing, but at the same time, what I meant to say is that be careful. That first-degree AV block that you see in an individual who doesn't have amyloidosis is different than first-degree AV block that you see in cardiac amyloidosis, because that's a sign that your conduction system has actually been affected by this deposition in the AV node, and then you may end up getting infra-Hessian deposition and even Hessian or infra-Hessian deposition. So if you see that, all I'm saying is that be concerned, get a good history, put a monitor, or ask them simply to walk. Because if you exercise this individual and they conduct with a first-degree AV block, then that's perfectly. Your disease is an AV node, nobody's going to be hurt. But if these first-degree AV block, if the disease is inside the Hess, or actually you have balanced left and right bundle branch block, then when you exercise them, you're going to end up with a significant block, and their mortality could be very high, because complete heart block is deadly, especially if a patient is doing fairly okay otherwise.
Yeah, we had a patient that had a right bundle, left intervesicular block, first-degree AV block, was fine. He didn't necessarily have an indication for pacemaker, and then he was driving in for an appointment and basically crashed his car and, had likely complete heart block. We put in a pacemaker, so that can happen. Sam, to your point, when I see these patients, I usually do a Zio patch for 2 weeks to look for occult AFib, and have a very low threshold to anticoagulate them. I think in summary, when I started here, you literally watch these people. It was a natural history experiment. They would just get worse over time. Their diuretics would go up, and they'd come in and out of the hospital. It's fascinating to follow these patients for 5, 6, 7, 8 years, and they're kind of hanging in there. And now with the antibodies, if they can hang in there and those get approved, we can potentially reverse it. So it's really been an explosive field, and it's really gratifying to see these patients come in year after year with minimal progression. So I appreciate everybody attending. Again, I want to thank the sponsors, Alexion, Alnylam, and AstraZeneca Pharmaceuticals, and we appreciate everybody attending. Have a great morning. Bye.